Good afternoon, everyone. Thanks for joining us for Medical Grand Rounds. Before we get started, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. I'd like to remind you to please leave your questions to the end of the presentation. Please enter them in the chat. As well, please answer a brief survey that will be sent to you immediately following the presentation. We are very grateful today to have a speaker from outside our institution invited to us by Dr. Tsoukis from the Division of Immunology. Dr. Tsoukis is with us today. Chris, would you like to introduce our speaker, please?
Sure. First, I'd like to thank Dr. Picard for accepting to give this presentation today on mast cell activation syndrome. Dr. Picard is well known to all of us in allergy immunology for the good work he's been doing on this particular problem. He obtained his medical degree from the University of Montreal in 2007, and then went on to complete his training in internal medicine, as well as allergy and immunology at the same university. In 2012 to 2014, he was in Boston working with Mariana Cassel, who is at the Women's and Brigham Hospital at Harvard University, the World Center for Study of Biology of mast cells, and in particular mast cell-associated diseases, period. He did some basic work there on hypersensitivity reactions to chemotherapy and worked on the model of mast cell mastocytosis and mast cell activation, and brought many of his skills back to Montreal, where he established and founded and established the division of allergy and clinical immunology at Maisonneuve-Rosemount since that time. And he's been very active, publishing extensively in the field, and I look forward to his presentation, as do many of our colleagues in our institution. So, Dr. Picard.
Thank you for the introduction and for having me. So the talk today we'll talk about mast cell activation syndrome, and hopefully by the end of the talk you'll have a better idea of what is a mast cell activation syndrome, but also equally importantly, what is not a mast cell activation syndrome. So here are my conflicts of interest, which I do not think impact the nature of the talk. You should know that Novartis is the maker of omalizumab, which I'll discuss briefly towards the end of the presentation. The objectives are to diagnose and classify a mast cell activation syndrome, and also to be able to order an appropriate workup and also the correct treatment for this syndrome. So what is a mast cell activation disorder or syndrome? So first of all, it is an episodic condition. It is not a chronic condition. So patients with a mast cell activation syndrome might have some chronic symptoms that they have almost daily, but those symptoms would not constitute the basis of the diagnosis for a mast cell activation syndrome. So the mast cell activation syndrome involves episodes which are acute, meaning that they occur abruptly, and they are of a short duration, usually several hours, almost never more than several hours, certainly not more than 24 hours. It needs also to be recurrent, so at least 2 episodes, and they need to be systemic, meaning involving at least 2 systems. And to be able to make a definite diagnosis of mast cell activation syndrome, the patient must meet 3 criteria. So the 3 criteria, the first one is to have typical signs and symptoms of mast cell activation. We'll get into what these symptoms are. Second, you need to have objective evidence of mast cell activation, usually through the measurement of serum tryptase during the episode, which then needs to be compared to the baseline tryptase of the patient. We'll discuss that. And third, the patient must be responsive to what we call anti-mediator treatment, most commonly antihistamines, and we'll discuss that also. The classic example of a patient with a mast cell activation syndrome is a patient with idiopathic anaphylaxis. So this is not such a common diagnosis, so you may not be aware of it. So basically, patients with idiopathic anaphylaxis have the classic anaphylaxis, as you all know, but without an allergic trigger triggering the anaphylaxis. So let's discuss the signs and symptoms which constitutes the first criteria for mast cell activation syndrome. This is by far the most important criteria. If you do not meet this criteria, in my view, you don't need to pursue other diagnostic testing. So first of all, mast cells are cells that are found throughout many tissues in the body, but the skin is probably one of the tissue with the highest level of mast cells. So when mast cells activate, there's almost always skin symptoms that will occur. One of the most common symptom is pruritus. It is very, very itchy, usually when mast cells activate in the skin. And secondly, you will commonly have some kind of flushing, often diffusely. You may sometimes have hives and sometimes even angioedema. So almost all patients with a mast cell activation syndrome during their episodes will have skin symptoms. Most commonly, you will also have cardiovascular symptoms through the hypotension created by mast cell mediator release. And that can translate into either dizziness, even sometimes syncope. And usually you'll be looking forward an objective evidence of hypotension. So for example, if the patient called 911, we will often review the emergency room file to see if there's evidence of hypotension. GI symptoms are also pretty frequent. We're talking about abdominal pain, vomiting, diarrhea, and this is because, again, there's many mast cells in the GI tract, and when they activate, that's the kind of symptoms they create. And the last system that can be implicated would be eye, nose, and lung. This is less common, I would say. But some patients will have prominent skin symptoms accompanied by acute rhinitis and conjunctivitis, like there's in the middle of the hay fever season, all of a sudden. That's compatible with a mast cell activation episode, but sometimes it might be more severe and might involve the lower airway and create bronchospasm and desaturation, but that's much more rare. And you'll notice here that I did not put forward throat symptoms like the feeling that the patient is choking, because this is almost never a prominent symptom of a mast cell activation episode. And also because throat angioedema is really not that common in patients with a mast cell activation episode. So again, you need to have two symptoms that are implicated. So for example, if you have a patient that have all of a sudden hives all over, angioedema, and it lasts for 24 hours and it resolves, this is what we would call acute urticaria and or angioedema. But because there was no other system involved, you would not call it a mast cell activation episode. And then sometimes the question that arises is, how do you differentiate that from anaphylaxis? In my mind, it's only a question of intensity of symptoms. So if you have prominent skin symptoms with some rhinitis and conjunctivitis, that's not anaphylaxis as defined by the diagnostic criteria for anaphylaxis, but it is certainly compatible with systemic mast cell activation. So just to make it clear in your mind what kind of patients, how those patients present and how the symptoms can translate into a real clinical case, I just put forward a case here. So it might be more common in women than in men, but there's no great epidemiological data on that yet. So let's say a 45 years old woman consults. She has no known allergies besides allergic rhinitis. And she consults because in the last year, she had several episodes of what she herself calls allergic reactions, but she could not identify any trigger. All her episodes are very similar and they start abruptly. She's fine, and the minute after, she starts having all those symptoms, and sometimes it happens in the middle of the night. So it wakes her up from her sleep. It also almost always begins by an intense itching sensation in her palms, and then she becomes diffusely flushed and diffusely itchy. She feels like she's going to pass out. She has abdominal cramps, often followed by diarrhea, and her symptoms resolve within several hours. Sometimes patients will take antihistamines like Benadryl during the reaction. Sometimes it's clear that it helps shorten the episode. Sometimes it's less clear, but this type of presentation is pretty classical for a systemic mast cell activation episode. And the other thing I would like to point out is that the fact that it happens, some of those episodes happen in the middle of the night, and because the patient has not been eating anything for several hours or did not take any medication for several hours before the episode started, we can be certain that there was no allergic trigger behind these reactions. So the second criteria, which is very important but difficult to obtain, is to measure an acute elevation of tryptase during the episode. So the tryptase is a protease that is specific for mast cells that is contained inside the mast cell granules. And so when mast cells activate, they release tryptase, and the level goes up in the blood and then is rapidly metabolized. It is very important to compare the acute level of tryptase to the baseline level to see if the elevation we're seeing or the level we're seeing is significantly elevated compared to baseline. So by expert consensus, the rule to define if the elevation was significant is we need to see a 20% elevation in tryptase plus 2. I'll show you an example of that. The difficulty in the measuring tryptase is that the measurement should be done quite soon after the mast cell activation episode started because it is very rapidly metabolized. And so ideally, it should be drawn within 4 hours of onset. Since the peak serum level is reached around 1 hour after the episode and the half-life is only around 2 hours. So just to show you what that means schematically, I put forward a theoretical example of tryptase elevation following a mast cell activation episode in a patient with a baseline tryptase here of 13. And I put here the dashed line for what the significant elevation threshold would be for a baseline tryptase of 13. So as you can see, if we obtain a measurement after 1 hour, even though the tryptase may not have rose much, so here from 13 to 20, which is a significant elevation, we would have picked it up. But let's say we do the measurement after 3 or 4 hours, you can see that in some situations where there was actually a significant elevation in the tryptase level, if we wait 3 hours or 5 hours to do the tryptase measurement, it's already down below the significant threshold elevation. So the take-home message here is when you interpret the acute tryptase measurement, you need to take into account 2 things. First, the intensity of symptoms, because if symptoms are severe, meaning that there was significant hypotension, we should see a higher level of tryptase elevation, and so it will take a little bit longer to get down to the baseline level. And second, you need to really look at the delay between the onset of symptoms and when the blood was drawn to interpret it correctly. The other thing that's pretty important to know about tryptase and mast cell activation syndrome is that an elevated baseline tryptase level, meaning a baseline tryptase of above 11.4, should not be used as a criterion for mast cell activation syndrome. We'll discuss this a little bit more later on, but this is very, very important to know. What is important to diagnose a mast cell activation syndrome is to look at the acute tryptase level and compare it to the baseline. Because sometimes in some patients, the baseline tryptase level can vary over time, it is recommended to obtain at least 2 samples at different times, so that if we have an acute tryptase level that is different from the baseline tryptase, meaning higher than the baseline tryptase, then we're more certain that the elevation we're seeing is real and not just a normal variation of the tryptase in that patient. And so ideally, you would want to have 2 baseline tryptase samples and 2 acute tryptase samples to be more certain. Do I always ask to my patients that they get this acute tryptase level measured before I make a diagnosis and offer them treatment? No. Reason for that is that it's pretty tough to get. So patients usually need to get to the ER pretty soon after having the episode to get it drawn. And because what we know of the difficulties of going to the ER these days, this is not always easy to do, except if the patient is using epinephrine and will get to the ER no matter what. Then I strongly recommend that if they go to the ER, that they get it drawn. But if the symptoms are not that severe and would not require them to go to the ER, and the symptoms are pretty typical and they respond well to treatment, then I do not insist on getting that acute tryptase level. But then by definition, you should make a diagnosis of probable mast cell activation syndrome, because you do not have any objective evidence of mast cell activation. Because of the difficulties of getting an acute tryptase level measured, people have looked at other mediators released by mast cells when they activate, to see if we could make the diagnosis through another means. So because the other mediators are metabolized in the serum even faster than tryptase, what people have looked at is that at the urinary metabolites of histamine, prostaglandin, and leukotrienes. So there's 3 nowadays that you can easily, I say easily with caution, because you still need to send this sample to the Mayo Clinic to get those mediators measured, but still that it can be reasonably done. So there's 3 mediators that can be measured in the urine. And again, as for tryptase, you need to compare the baseline level and the acute level. So to obtain the baseline level, sometimes you can use a 24-hour collection, but you can also do it on a random urine sample. When you measure it acutely, because these metabolites need to be produced in the blood and then excreted in the urine, you should wait a couple of hours following the episode to do the random urine sample. So if it is recommended to throw away the first urine and to keep the next one. But sometimes I will say to patients, if your next urine after your episode is only 4 to 6 hours later, then I would keep this one because it's reasonable to think that these mediators have had time to be excreted in the urine by that time. So there's no definite cutoff, but I'd say sometimes somewhere from 4 to 6 hours after an episode is a good window to measure those mediators in the urine. Unfortunately, compared to tryptase, there's no consensus as to what would be a significant elevation. There's a proposal which has been made by experts in the field. So they propose that a 200% increase over baseline, and if the level is also above the upper limit of normal, should be considered a significant elevation. But you should keep in mind that it's less specific than tryptase. There's other conditions that can create a rise in, for example, leukotriene in the urine, which would not constitute a mast cell activation episode. Just to show you what it might look like, I put here a clinical example that was published in a review article on the subject. So as you can see, that patient had an acute episode and could have the tryptase measured during the episode, and you can see that the tryptase rose over this the threshold for a significant elevation, which in that patient would be 7.6. So it rose to 8.7. But let's say you could not get it done. You could have looked at the mediators in the urine and see a 350% increase in the prostaglandin level and more than 1,000-fold increase in the level of leukotriene, and both of which were above the upper limit of normal, as you can see here. N-methylhistamine might be less sensitive than these other two, but usually what we do is we measure the three mediators on the same sample, because if you have, the more you have mediators that increase, the more likely is your diagnosis. And again, as for baseline tryptase, baseline levels of urinary metabolites should not constitute a criterion for mast cell activation syndrome. It is really the difference between the acute level and the baseline level that should be looked at, and not the absolute level acutely or at baseline. And I just gave you here an example of a patient I followed, and that patient had advanced systemic mastocytosis, but besides having this condition, she never had, throughout the course of her disease, she did not have a single episode of a mast cell activation. But that patient is probably the one with the highest level of N-methylhistamine and prostaglandin in the urine that I've seen, and also the highest baseline tryptase level I've ever seen. And that patient had no mast cell activation syndrome. So just an example to tell you that other conditions can influence these baseline levels, and that does not translate into mast cell activation syndrome. The other thing that we'll discuss a little bit more in detail further is that there's about 5% of the normal population that has an elevated baseline tryptase level, and this is because they have a genetic condition called alpha tryptasemia, but this is not a disease. Alpha tryptasemia is just a genetic trait, or a genetic condition, and most of those patients are totally asymptomatic. So again, elevated baseline tryptase level does not mean anything with regards to a mast cell activation syndrome. And here's the third criteria. So response to anti-mediator treatment, most commonly antihistamines. So there's two ways to look at that. You can either look if acutely your patient responds to antihistamines and or epinephrine, depending on the intensity and the severity of the symptoms. But sometimes patients with frequent episodes will try prophylactic treatment, often as a first line with antihistamines, and then we assess if the episodes are less severe and less frequent. And if the answer is yes, then we consider that they meet the third criteria. So again, a clinical case, a clinical example of a patient with a probable mast cell activation syndrome. I say probable because in that particular case, we did not bother getting the tryptase measured acutely because as I show you, the patient had typical symptoms and responded very well to a simple treatment with cetirizine. So that patient had for the last 3 years multiple episodes. Again, acute onset of nasal congestion, hives, and sometimes angioedema of the face, sometimes abdominal pain, and sometimes dyspnea. These episodes would last for 2 to 3 hours and then completely subside. Symptoms were somewhat better if she took an antihistamine, and we could not find a specific trigger. Sometimes it happened after eating, but then she would eat the same meal again and would not react. Sometimes it happened after physical exercise. As I'll show you, exercise is a common trigger for mast cell activation episodes, but it also happens sometimes at rest. So we started her on cetirizine at a usual dose of 10 milligram a day, and episodes became less frequent and less intense, but she still had some episodes. So we increased the dose to 20 milligrams, and then it completely subsided. So because she had a very good evolution under well tolerated and not uncomplicated treatment, we did not think it was necessary to get the tryptase measured accurately. But we still did a baseline tryptase because this is part of the normal workup we should do, and it was normal, so no further testing was necessary for that patient. So nowadays, I feel the need to discuss specifically what is not a mast cell activation syndrome. And the reason behind that is that there are more and more patients that are referred to us with mast cell activation syndrome ? And oftentimes, or to not say almost always, those patients do not have a mast cell activation syndrome. And it's usually unclear what they have. So the thing is that on the internet, it has become a thing to try to explain a whole bunch of symptoms that are most often chronic, but sometimes episodic. I'd say they can be vaguely suggestive of mast cell activation, but they're really not the typical mast cell activation symptoms that I've just shown you. So those patients usually complain of frequent flushing, sometimes diarrhea, sometimes constipation. They have abdominal cramps, they have headaches, they have brain fog, they have orthostatism, they feel very fatigued, they sometimes have throat symptoms. Oftentimes those patients will be very sensitive to strong odors like perfumes and stuff like that. So they have a whole bunch of symptoms, and usually they come in with a huge list of symptoms that involve all kinds of systems. And they've read on the internet that the answer to their problem could be a mast cell activation syndrome. So first of all, I'd like to say that there is actually no scientific evidence for what we would call a chronic mast cell activation syndrome, meaning a low-grade mast cell activation that would create those chronic symptoms so that patients would always feel unwell. There's just no evidence behind that. Often also when you question them on the use of antihistamine, they'll have tried some antihistamines, but they often claim that they do not tolerate them. Sometimes they'll complain of palpitation. Sometimes they tell you it makes them very drowsy, so they cannot take it. Other patients will have tried first-generation antihistamines, and they found that it helped acutely their symptoms. And so they take that as a proof that it's mast cell activation that is the cause of their symptoms. But as you know, first-generation antihistamines have other effects, off-target effects, I would say, besides being antihistamines. They also have prominent neurocognitive effect, and there's certainly a component of placebo effect that can be that can explain why they feel better when they take this medication. I even had one patient that told me that Ativan made her feel much better, and for her it was a proof that she had mast cell activation. And when I told her, well, you know, Ativan is an anxiolytic, it's not an antihistamine, she said, well, I've read on the internet that Ativan is actually a mast cell stabilizer. And I said, I'm not aware of that effect. But she remained convinced that she had a mast cell activation syndrome. Those patients are very tough to deal with because they've often seen multiple specialists. They've read a lot of things on the internet, and they've become convinced that this is the answer to their syndrome. Sometimes they carry other diagnoses like chronic Lyme disease or Ehlers-Danlos syndrome. I have to tell you that there's no connection that has been shown between Ehlers-Danlos syndrome and mast cell activation syndrome. And those patients are often disabled. They do not work because of all their symptoms. So you might ask yourself, why is it that they've read this on the internet? Where does it come from? So it comes from doctors, which for most of them, if not all of them, they're not allergy specialists. I've looked up the background of some of their doctors. They're the same ones that put forward chronic Lyme disease, functional disorders, and stuff like that. And those doctors have come together and proposed a diagnostic criterion for mast cell activation syndrome, and they called their consensus 2, because they thought the consensus 1, which is the one I presented to you, made by allergists and published in good journals, they felt it was too restrictive. But I have to say that I've looked at these criterion, and I'm just going to show you some of the things, just to show you that it is, in my view, not based on any good science. So first of all, they list potential manifestations of what they call mast cell activation disorder, MCAD. And here, I'm not going to read all of this to you, but I just wanted to show you that it fills 3 slides. So I'm not aware of any condition that would produce a whole bunch of symptoms that would be so diverse as to fill out a table that is that long. And they even say that this list is not complete for all the symptoms that could be created by mast cell activation syndrome. So basically, they say any symptoms could be caused by a mast cell activation syndrome. And here, if you look at their criteria, it looks scientific. And I have to say that you have to know your stuff quite good to be able to detect the problem with those criteria, because they look legit. But if you look at it, the 2 things you need to be able to be diagnosed with a mast cell activation disorder according to their criteria is to have any of the complaints or the manifestations I just showed you in table 1. So basically any symptom. And second, any evidence of above normal levels of mast cell mediators. So meaning here that if you have an elevated baseline tryptase level, this is good enough for them. If you have an elevated histamine level either in the blood or the urine, this is good enough for them. And then they even go into other mediators that truly are found in mast cells, but have never been, to my knowledge, studied in correlation with mast cell activation. So they list heparin and chromogranin A as mediators that could be measured. And if you find a above normal level, this is good enough to make a diagnosis. So this is quite hard to explain to patients, that even though it's published in scientific journals, albeit not very good ones, even though it's criteria that are proposed by certified doctors, this is not a condition that is supported by the good, I'd say, scientific literature. So just that was, I think, important to make clear before we go on, because this is something that I think some of you at least will encounter patients with that claim to have a mast cell activation syndrome. So let's go back to the patients with a definite diagnosis of mast cell activation syndrome according to the criteria presented to you in the first place. So once you've established a probable or a definite diagnosis of mast cell activation syndrome, the second question that should be in your mind is, what could be the cause behind that? So first of all, I'll tell you that most of those patients fall into the idiopathic category, either the idiopathic mast cell activation syndrome or as idiopathic anaphylaxis, if most of their episodes qualify for anaphylaxis. but you still need to rule out either a primary or clonal disorder or a secondary cause for the mast cell activation syndrome. So first of all, there is one main condition to rule out as a primary or clonal condition, and that is indolent systemic mastocytosis. So a clonal disorder of mast cells that can truly increase the risk of either idiopathic anaphylaxis or having episodes of mast cell activation that would not qualify for anaphylaxis, but that would again be either caused by an allergic trigger or no allergic trigger. So that is for indolent systemic mastocytosis. I'll discuss this in a little bit more detail later on. There's another much more rare diagnosis, which we call monoclonal mast cell activation syndrome. So those patients with monoclonal mast cell activation syndrome are about the same as those with indolent systemic mastocytosis. But even though we find some evidence for clonal mast cells, patients in the monoclonal mast cell activation syndrome do not meet all the necessary diagnostic criteria to qualify for an indolent systemic mastocytosis. There are other clonal disorders of mast cells, which most of these other conditions would not cause, in most patients, mast cell activation episodes. But cutaneous mastocytosis is a condition where clonal mast cells are found only in the skin. This is especially common in children because most adults with cutaneous mastocytosis or mastocytosis in the skin will have an indolent systemic mastocytosis, around 80%. But children with a diffuse subtype of cutaneous mastocytosis can sometimes also have episodes of mast cell activation, of systemic mast cell activation. And then there's a last category, which include aggressive systemic mastocytosis or indolent systemic mastocytosis associated with another hematologic neoplasia. But most of those patients, as the patient I presented to you earlier, do not have symptoms of mast cell activation. So it's pretty uncommon for those patients to be referred in allergy as a first place, because they will usually present like they have a cancer with weight loss, night sweats, organomegaly, abnormal CBC. So those patients usually get worked up by hematology, and it's through a bone marrow biopsy that they see evidence for mastocytosis. But usually most of those patients will not have mast cell activation symptoms. The secondary category is important to keep in mind because you do not want to diagnose an idiopathic condition to someone that has a specific trigger for their episodes. But it's quite rare that an IgE-mediated food allergy would have gone unrecognized for a year in a patient with multiple episodes of mast cell activation episodes. So the reasons it's put here is because there are these rare food allergies that could be that could be missed. It has to be suspected, I would say, only for patients that have meal-related episodes, because if the episodes, like I said earlier, occur in the middle of the night or after the patient has not been eating anything for, I'd say, more than 3 to 4 hours, an IgE-mediated food allergy can generally be ruled out without further workup. But I've already seen a patient that for a year had multiple of meal-related mast cell activation episodes, only to find that the problem was that she was using pepper mixed with buckwheat, but she had not recognized that there was buckwheat mixed with the pepper. And so she sprinkled pepper mixed with buckwheat on many of her meals and had an allergy to buckwheat and had multiple episodes every time she sparkled the buckwheat on her meal. And that took a year for her to realize that she was using pepper mixed with buckwheat. So just something to keep in mind. A quick word on patients that have severe reactions to wasp or bee stings, so Hymenoptera stings. Severe reactions to Hymenoptera stings can be an indicator that there is a clonal mast cell activation disorder, which can predispose to mast cell activation syndrome. And so usually we work up those patients as a mast cell activation syndrome. And there's also, I'll briefly mention another condition which looks a little bit esoteric, which is called exercise-dependent anaphylaxis. So that would be patients that only have episodes of mast cell activation after exercise. And we also have a subcategory of food-dependent exercise-dependent anaphylaxis. So if episodes only happen after exercise, we need to assess if that is not the more correct diagnosis for those patients. And then we think there might be an hereditary condition, which I briefly mentioned before, which we call alpha-tryptosemia, that could increase the risk of having a mast cell activation syndrome. But as of now, we do not think it causes mast cell activation syndrome because, as I said, it's pretty frequent in the normal population to have alpha-tryptosemia, and most of their patients are asymptomatic. So as of a workup, what we should do, first of all, is just have a quick look at the skin of those patients to make sure they do not have skin mastocytosis, most commonly the form urticaria pigmentosa, of which I've put a picture here. Then if there are meal-related episodes, these patients need to have a thorough food allergy evaluation. And I'd say most importantly, a baseline tryptase should be measured. And if the baseline tryptase comes back as elevated, then we need to look at what might be causing that, keeping in mind that the most common by far diagnosis is alpha-tryptosemia, followed by chronic kidney disease. And then there's this 1% chance of having a clonal hematologic disease, including an indolent systemic mastocytosis, which is a very, very, very rare diagnosis. So most of your patients with an elevated baseline tryptase will either have alpha-tryptosemia or chronic kidney disease. So what is alpha-tryptosemia? So it's a condition we're aware of since only, I think, about 2016. So what's been discovered is that there are two locus for the tryptase gene, the beta tryptase locus and the alpha tryptase locus. And in some patients, the alpha locus becomes either duplicated or triplicated, and that causes increased production of baseline tryptase. And that's been found to be quite common, affecting about 5 to 6% of the normal Occidental population. And the only way to have this genotyping done as of now is to send a buccal swab to a company in the US called Gene by Gene, which can assess the tryptase copy number variant. So because it is common, people have looked at what manifestations could be associated with alpha-tryptosemia. It's not easy to do because you need to compare it with the normal population, with a match population. But one thing that's for sure is that those patients truly have an elevated baseline tryptase. So alpha-tryptosemia becomes more likely when baseline tryptase is above 8, but most commonly above 11. So I would only order it if the baseline tryptase is above 11.4. I've bolded here manifestations that's been correlated with alpha-tryptosemia in more than one study compared to a normal population. So we think that patients with alpha-tryptosemia have a higher likelihood of having systemic mast cell activation episodes and also systemic reactions to Hymenoptera stings. It's unclear why at this time, but we've also observed that alpha-tryptophanemia is more common in patients with either systemic mastocytosis or idiopathic anaphylaxis. And the reason behind that might be that those patients with alpha-tryptophanemia are more likely to be symptomatic of another condition that causes mast cell activation, like systemic mastocytosis or idiopathic anaphylaxis, and therefore they might be more likely to seek medical attention. And in support of that hypothesis, it's been found that patients that have both, so alpha-tryptophanemia and mastocytosis, tend to have more severe anaphylaxis, meaning more cardiovascular symptoms, compared to patients that only have systemic mastocytosis but do not have alpha-tryptophanemia. So if your baseline tryptase is above 11.4, and you have a normal tryptase genotype, so your patient do not have alpha-tryptophanemia and the creatinine is normal, then you should look into a clonal hematological disorder. So to look at that, one easy test to do is a blood draw to look for the mutation that is most commonly found in indolent systemic mastocytosis. This mutation can be detected in the blood. The problem is, as of now, that the PCR test we're using here in Quebec is not as sensitive as the one that's used in referral centers in the US. So the detection threshold of our PCR test is 100-fold higher than the reference test. So, so it's not as good as the one that's been used in referral centers. And so if you do not detect that mutation in the blood, it's unclear what the probability of a clonal hematological disorder is. But if it is significantly high because of other findings, then you should go on with a bone marrow biopsy if you want to confirm a diagnosis of systemic mastocytosis. So it's always unclear which patients in which patient it should be performed. I think it's a no-brainer that if you have an elevated baseline tryptase and an abnormal CBC or other findings of neoplasia, that you should get the bone marrow biopsy. If you have an adult patient with skin mastocytosis, then I think it's a good indication to do it, because there's a high likelihood of finding a systemic mastocytosis. And if you do, it changes how you will manage the patient. And in some cases, it's the only way actually to confirm a diagnosis of indolent systemic mastocytosis. So if you want to be certain of the diagnosis, then you need to do the bone marrow biopsy. But there's a risk of false negative results, and I've seen that. So you really have to to talk with the pathologist and make sure that the study of the bone marrow will involve all the necessary to make sure that that if there is systemic mastocytosis, it will be found. So I'll end up with talking about treatment. So you'll see this section is quite short because it's, I think, pretty simple. So usually we order a treatment that is symptomatic. So we either put the patient on daily medication prophylaxis if the episodes are frequent, or an as needed therapy if episodes are not so frequent. And if there's a specific trigger like exercise, then they can use it only before exercising. So what we use is what we call anti-mediator treatment, most commonly anti-H1 treatments, sometimes anti-H2, especially if the patient has GI symptoms, sometimes montelukast to block leukotrienes, especially for respiratory symptoms, and sometimes aspirin to block prostaglandin production. There's other drugs that can be used like tromelin, ketotifen, and omalizumab, but they're rarely needed. Just a quick word on aspirin and mastocytosis, just to say that there's maybe a 5% chance that it might exacerbate symptoms. And so if the tolerance of that patient to NSAIDs is unknown, we prefer to do challenge before prescribing it. And it has been shown to be helpful in some patients that overproduce prostaglandins, as can be demonstrated by urine analysis, and it can help prevent episodes of flushing and hypotension. Naltrom, cromolyn, which is the oral form, can be used, especially in patients with refractory GI symptoms. It needs to be taken 4 times a day. It can be costly for patients because it's not covered by every insurance company. And in my experience, it's often not so effective. So it's not a great drug. It has mast cell stabilizing properties, so that's why it's used, but not so efficacious for many patients, but can be tried. And there are very, very rare patients that continue to have episodes despite all the other mediators we've tried. And so people have looked at the efficacy of omalizumab. There's only one randomized controlled trial that's been done at the NIH for omalizumab in idiopathic anaphylaxis in patients that had failed a trial of prednisone for their condition. And unfortunately, this study was negative. It might have been underpowered or not long enough to detect a significant difference, but the result as we have it now is that the study was negative. And so I'll just skip on that and just conclude by reminding you that a mast cell activation syndrome is a syndrome where there are recurrent episodes of typical symptoms of mast cell activation, where you should demonstrate ideally an elevation of the tryptase level, and patients should be responsive to anti-mediator treatments. There are many possible causes, but most frequently it is idiopathic. And the workup should include a baseline tryptase, very rarely a bone marrow biopsy. And most commonly, treatments will revolve around antihistamines, sometimes moltiducast. And obviously, if the patient has had anaphylaxis, he should carry an epinephrine autoinjector. And now I will take questions.
Thank you so much, Dr. Picard, for this really comprehensive review of this very, very important and complex topic. Chris, before I give you the floor, well, there's a comment from Dr. Gilfix here about how we get tryptase at the MUHC. And Derek Lanoux has a question about the use of modafinil for fatigue syndrome or Adderall for brain fog. These patients occasionally have this syndrome. Any comments on that?
So first of all, the tryptase level is pretty easy to do. It's actually sent to you at the MUHC. So if we draw it here, it's at the MUHC that it's measured, and it's only a serum sample that is needed. So there's you just need to be aware that it can be ordered, and just order it on a serum sample, and that's it. As for Adderall, modafinil for brain fog, it's not a drug that I prescribe. It's unclear because truly there are patients with either indolent systemic mastocytosis or mast cell activation syndrome that will also complain of brain fog. It's completely unclear what the cause of that could be. And so I'm not, I don't feel comfortable prescribing these drugs because I've never used them, but so I cannot comment under efficacy, but if it works, why not?
There's somebody with their hand up. You have maybe 2 minutes if you want to unmute yourself. Dr. Lemire, is that right?
Yes, it is. Actually, it's just to correct your comment. The Dr. Gilfix comment is the tryptase copy number, which is the assessment for alpha tryptase, and that they don't. So it's an out of province test. So it's not the tryptase level that he was talking about. So they do not do the buccal swab. They do lavender top. Blood. Actually, they take a blood vial with a lavender tube, and that's what they send out to gene by gene, just from an allergist point of view.
Fantastic, thank you. Chris, do you want to say a few words?
Well, I thought this was a an excellent presentation, very comprehensive and clear. And I think one point that was very important for us is who does not have the syndrome, because probably we see more patients being referred that don't have the problem than do. And I thought that was very useful for all of us. I've been kind of surprised that mast cell stabilizers are not used more extensively. And I understand your comments that you haven't found them to be all that effective, and yet they were specifically developed for that purpose many years ago. Do you have any comments as to why this may be the case? Is this just a question of getting them absorbed, especially to the target organ that's required? Why do you think that is so?
So oral cromolyn is theoretically not absorbed systematically, so that could explain why it's not working. As for ketotifen, which has mast cell stabilizing properties, I don't use it because it also has sedating side effects. And I've never really found the need to go there, because usually most of my patients will respond quite well to second generation antihistamines, and so I did not feel the need to try ketotifen in those patients.
Okay, well, thank you. I don't know if anyone else has any other questions or comments.
Yeah, there's a question here by Henri Menard. Shouldn't pseudo-allergic reaction be physiopathologically classified as some kind of MCAS? I'm referring to ampicillin rash during infectious physical urticarias. Any comments on that?
Yeah, so regarding maybe chronic urticaria, physical urticaria, it truly is the result of an abnormality in the skin mast cells. But because it's not a systemic mast cell condition, and so the diagnosis remains of either physical urticaria or chronic urticaria, but you can see it as a mast cell activation disorder of skin mast cells. Regarding ampicillin rashes and stuff like that, the mechanism is completely different because it would not involve mast cell activation, and it would usually be caused by T cell activation. And so mast cell would not be implicated in delayed rashes to antibiotics.
Fantastic. We're coming up on the hour, so we will have to close off the presentation. Thank you. Really outstanding, comprehensive lecture on the topic. Chris, I will give you the final word. Thank you, Dr. Picard. Chris, I'll let you close up.
Well, I just want to thank Dr. Picard for the wonderful contribution he's made to the practice of allergy and immunology here in Montreal. And this is wonderful to see that you have such expertise that is critical today, because of the fact that so many patients go to the internet to get this kind of information, and we need clarity. And I thank you very much for your presentation today.
Well, thank you very much.
Thanks, everyone, for joining us. Have a great afternoon. Bye-bye. Thanks, Dr. Picard. Bye-bye.
Thank you.
Bye. Thanks again.
Thank you. Bye-bye.